welcome to Conversations with Dr. Kohli. I'm your host, Dr. Kohli, non-invasive and preventive cardiologist. And today we're talking about something you may all have wondered about. How do you think about residual risk beyond LDL in your ASCVD patient? And specifically, how do you interpret hypertriglyceridemia and how to reduce a patient's risk based on their triglycerides? Today, I'm delighted to be joined by my colleague, Dr. John Osborne, who is the founder and director of State of the Heart Cardiology and also the Chief Medical Officer of Clear Cardio. Welcome, John. Thank you for joining me.
Thank you so much for having me on today, Dr. Kohli.
So, John, I want to start just by talking a little bit about residual risk beyond LDL cholesterol. Today in 2024, we know that there's so much more than just LDL. Of course, when we think about reducing risk, we start with LDL. But beyond LDL, we know that patients go on to have events, even though they're well treated with their statin, their LDLs are lowered. So how do you think about your ASCVD patients in terms of other risk pathways and what you might start to target once you've kind of gotten to where you need to get to with that LDL threshold?
Sure. Yeah, I think, in 2024, we're blessed by having an incredible, highly effective, clinically proven number of tools to lower LDL. We went from only 10 years ago, from basically having statins to having a number of proven therapies. I think where we tend to miss opportunities for risk reduction, however, is in the triglyceride space. And I think more recent studies done now in the last several years, particularly the REDUCE-IT trial and other trials that really back up that message, really have underscored two things. One, triglycerides really are important. They really do identify a higher risk individual that is independent of LDL. And that, as it turns out, if you look at the science behind it, to further lower that risk, there really is only one proven agent, which is icosapent in that particular hypertriglyceridemic patient that still remains hypertriglyceridemic and even modestly hypertriglyceridemic above 135 milligrams per deciliter in our patients who have well-established, well-controlled LDL cholesterol.
I really like that. I like to think about triglycerides as sort of a target sign on my patient, T for triglycerides and T for target. And it really earmarks for us, as you said, the patients that might be higher risk. Other pathways that I'm sort of thinking about in 2024, of course, are lipoprotein A, which we know is sort of this parallel pathway to LDL as well as triglycerides. We think about obesity and inflammation. We have anti-inflammatory medications. We have obesity medications like GLP-1 receptor agonists that can also help reduce cardiovascular events. And then we think about thrombosis in certain patient phenotypes, especially, for example, PAD patients or those who smoke with low-dose rivaroxaban, for example. So many pathways to hit. A good problem to have as a cardiologist that we have a lot of pathways. But let's focus in a little more on those triglycerides that you brought up. And I specifically want to talk about how you think about triglycerides. Do you treat to a target triglyceride? You mentioned kind of moderate hypertriglyceridemia. What's sort of your rule of thumb when it comes to thinking about triglycerides? Do you get them down, keep them down, or do you just think about risk-reducing medications?
I'm going to get back to the literature. The best literature that we have in this particular space of hypertriglyceridemia that also has proven clinical benefit really says that those patients with modestly elevated triglycerides, and to be specific, we're talking 135 to 499, those are the patients that were enrolled in the REDUCE-IT trials.
And it's funny because a few years ago, we would have ignored these patients, but now you're telling me I should be thinking about them.
Most certainly. And in fact, as you're well aware of too, if you look at triglycerides as an independent risk factor beyond LDL, risk starts at about 70 milligrams per deciliter. Yeah. So probably even far lower than we even had thought about before. But I think the REDUCE-IT trial is critical because A, it identified this especially high-risk population that we think they're well treated with statins. We can identify that they are a high-risk population. And furthermore, importantly, not only can we identify them, but we have been given guidance as far as what we can do to further lower that residual risk. And as it turns out, that approach is using icosapent. I think importantly, the message here is once they're on therapy with icosapent in these patients with modestly elevated triglycerides, it's not about lowering the triglycerides per se, it's about identifying the biomarker that identifies a patient population at higher risk and at the same time coupling that with a proven therapeutic approach, which is the use of icosapent ethyl in those patients. The way I communicate to my patients is I think of it sort of like aspirin, right? Or even other antiplatelet drugs, or even the novel oral anticoagulants, right? When we use those drugs, we don't really, you can, but we don't really test for platelet reactivity on those drugs or factor 10A activity on a NOAC, right? We just know that's the right dose that delivers the goods and is both safe and effective. And I think we need to think about icosapent ethyl the same way, because we know that the benefit is completely independent on treatment triglycerides. So it really is using triglycerides as a biomarker for additional risk, coupled with the great, really practice-changing data we have from REDUCE-IT and many of the other trials and studies based on that, and other studies that also back up that same concept, that it's a high-risk population and that we have highly effective therapy that helps to lower risk in that population.
I really love that. So you're treating the risk, you're not treating the number. And that's something I think we as cardiologists are so goal-oriented. We love to think about the number. But in this case, as you pointed out, you really want to think about the risk and not necessarily what those triglycerides are. So let me push you on this a little bit, because, REDUCE-IT, which I think is a fabulous trial, but it was done before the era of GLP-1s, really in cardiovascular medicine. And more recently, we have data from the SELECT trial that tells us that GLP-1 receptor agonist in obese patients with cardiovascular disease can have a 20% MACE reduction, and you start to see some of those benefits even before the patients have lost weight. So if I'm a clinician at the bedside and I see somebody with high triglycerides and maybe they're obese or overweight, wouldn't I want to go upstream and think about treating the obesity first to think about lowering those triglycerides and then recalculating the risk? Or how do you think about this in your patient population?
Yeah, I see all of these different MOAs, mechanisms of actions, as additive. And if you compare and contrast, which again is sort of statistically illegal, but I'll do it anyway, between SELECT and REDUCE-IT.
We won't tell.
Exactly. And then also throw in some surrogate data that might be useful, that we do know from surrogate trials, and then we'll get to the randomized double-blind placebo-controlled trials, that from surrogate trials, interestingly, from Matt Budoff, who did both of these trials, that in the EVAPORATE trial, we had a proven anti-atherosclerotic effect. We had an increase in calcified plaque, a lowering of lipid-rich plaque, which is really, I think, the goal of treatment of atherosclerosis at the molecular biology vascular level. When he did the similar trial with semaglutide, we really didn't see much effect on plaque. Now, clearly from SELECT, we know these drugs work. They work in non-diabetic patients because that's the population we looked at in SELECT. But also, interestingly, if you look at those individual endpoints, a 28% reduction in MI rates, but no difference in stroke and no difference in cardiovascular mortality. If you look at REDUCE-IT, again, different trial, different population, different intervention. There, we saw very uniform reduction in major adverse cardiac events, including a 28% reduction in fatal and non-fatal stroke and a 20% statistically significant reduction in cardiovascular death. So for those reasons, I think these are different approaches. I think they're complementary. I don't think it's a choice of one versus the other. Now, I think the clinical challenge is, okay, so we have the data from SELECT ringing in our ears. We have REDUCE-IT ringing in our ears. Do you start with icosapent ethyl and then look at the approach of using GLPs or a variety of benefits, including weight loss and cardiovascular risk reduction? Or do we start with those and then look at the patients and look at the triglycerides and see how they're doing? I think that's where, the practice of medicine comes in. We don't have good science to tell us which of those things we should do. So what I'm going to do is I'm going to err on caution. I'm going to err on the side of the benefit and the benefit to patients. So I'm going to use these as really two separate tools. I think they're both fantastic. I'm glad that we have multiple different complementary mechanisms of action to further ratchet down risk and residual risk in our patients. And I think all of these are great tools. I think the challenge is that we have great data with REDUCE-IT, but we're still not targeting that pathway. That's where the opportunity is.
Well, I mean, John, this has been a really interesting and scintillating conversation. I know I've learned a lot about how to think about risk in my patients. And I really want to highlight the point you made about parallel pathways, because different mechanisms of actions means different biological effects, and it's not one or the other. But now we have so many tools in our toolbox that we can bring to the bedside. So maybe our kids and their kids won't have to grapple with atherosclerosis quite as much as we have had to.
Exactly. I like to say atherosclerosis is an endangered species, and I'm delighted about that. And I really applaud everything you do in your practice and your national and international approaches to preventive cardiology, getting the message out. It's fantastic. And ultimately, why I'm here, and I think probably you'll admit why you're here, is really that ultimately we work to put ourselves out of business.
I love that. And we can retire and write history books about it. So thank you again. Thank you so much for joining me today. I've really enjoyed sitting down with you. And thank you all for joining Conversations with Dr. Kohli. Please write in with questions, comments, and reactions. And take care until next time.
Thank you again, Dr. Kohli. Have a great day.
You too.